Sorry for any inconvenience for this morning. Uh, Joining us from Egypt, my family, who would want to miss this point? So, my family, this is everyone. Everyone, this is my family. Okay, so thank you for coming today for my dissertation defense, which is entitled Linking Physical Therapy Outcome Measures to the International Classification of Functioning, Disability, and Health after Triangular Fibrocartilage Injuries and Ulnar Pain. So basically what I'm going to talk about is health conditions in this area of human body. And in this area of human body, we have a complex anatomical structure and overlapping differential diagnosis. That's why some authors have referred to the ulnar side of the wrist as the black box, and some others compared it to the injuries of the low back pain in terms of the chronicity. On top of the sources of ulnar wrist pain comes the triangular fibrocartilage complex, the TFCC as abbreviated from now on. As you can see, it's triangular. It's between the ulna and the ulnar corpus of different ligamentous and cartilaginous structure that support the ulnar side of the wrist. This structure also has an articular disc and meniscus homologue that is analogous to the meniscus of the knee in terms of the morphology, the mechanism of trauma, and the blood supply. Among other causes of ulnar wrist pain comes the lunotriquetral ligament injuries depicted here in this MRI picture, and the extensor carpi ulnaris subluxation tendon, which runs through here. You can see here the triangular fibrocartilage complex, the triangle in shape, and it's perforated, indicating an injury. So the function of the TFCC is to provide major stability to the radio-ulnar joint, distal radio-ulnar joint during supination and pronation of the forearm. Second, to provide stability to the ulnar side of the wrist. By doing so, it allows a smooth transmission of weight across the ulnar side of the wrist. When it's intact, around 20% of the load is transmitted through the TFCC. Also, it has an important function that facilitates the action of the extensor carpi ulnaris tendon through maintaining a normal excursion of the tendon during extension ulnar deviation of the wrist. So some proposed treatment method has been published, but unfortunately these were just based on empirical research and experts' opinion. Nothing was standardized yet. Among these published data, a treatment algorithm which was centered around the use of ulnar gutteral split or minus strengthening exercises to treatment of ulnar side wrist pain. Because these data were not standardized yet, our first motive in this study was to kind of have an evidence for using of these intervention in treatment of ulnar wrist pain. So if the ulnar wrist pain causes functional problem, the intriguing question is how can we link that to the ICF, the International Classification of Function? And how can we use the International Classification of Function as a model to represent this health outcome? In doing so, we have to shed some light over the model itself. 2001, the WHO published this model of functioning, which has three main domains: body function and structure, which can be impaired; participation, which can be restricted; activity, which can be limited. These three domains interact with one another and are influenced by external factors like environmental and personal factors. In 2009, they extended their classification to 23 list of subcategories pertinent to the hand and wrist conditions. They named this categories the ICF core set for hand conditions, and this model was studied before, so that on different health conditions. So my second intention in this study was to apply this 23 categories to the subjects of ulnar wrist pain and linking them to the physical therapy outcome measures. As you can see, it's been rheumatoid arthritis, hand arthritis, distal radius fractures, and in muscular on different rehabilitation stages. This being said, we have two purposes for this study. First, to investigate the effect of splinting plus splinting plus strengthening in treatment of ulnar wrist pain, and to apply the brief ICF course set for hand conditions to the physical therapy outcomes after the TFCC injuries and ulnar wrist pain. Consequently, we had two research questions. First, will splinting compared to splinting plus strengthening reduce pain, improve function and strength in subjects with ulnar wrist pain? Second, can the brief ICF course set can be used as a list of subcategories to define and describe subjects with ulnar wrist pain? So how did we do that? We had two research papers out of this study. The first research paper was a randomized, single-blinded parallel groups clinical trial. The participants' age ranged from 18 to 53. We included them if they have acute or subacute injuries of the TFCC, ECU tendon, or leonotricutal ligament. We excluded them if they have non-traumatic conditions of wrist and hand, or associated distal radius fractures, or radial-sided wrist pain, or if they have gone through any surgery on the upper extremity through the past 6 months. We built this flow chart according to the consolidated standards of reporting clinical trials. So we screened 5 subjects as baseline, excluded 5. 2 of them had ulnar wrist pain more than 6 months. 1 of them had associated distal fracture. Another one with Kienbock's disease, which is a vascular necrosis of the leonate bone. 1 with rheumatoid arthritis. Randomized the remaining 30 into 3 groups, 10 each. The first group received orthotics intervention. The second group received orthotics plus strengthening exercises, and the third group received placebo tennis elbow brace and served as a control. We lost 1 subject at follow-up in group 1 and another one in group 3. We analyzed our data based on the remaining 28 subjects. So at baseline, we took pertinent data like age, gender, hand dominancy, injured hand, activity level, duration of symptoms, and sources of pain. Then we performed these 6 physical exam tests: the piano key test, the piano key sign, the TFCC compression test, the ulnar sign, press test, lunotriquetral compression test. These tests can be depicted here. This test is called the ulnar fovea sign, where we palpate the ulnar snuff box for tenderness and pain, and it has a sensitivity of 95% and specificity of 86% in detecting foveal pain and disruptions of the ligament at the ulnar side of the wrist. Also, this test analogous to the MAC of the knee, where we squeeze the meniscus between the ulna and the carpal bone to kind of provoke and reproduce the symptoms. This test also has a 100% sensitivity of diagnosing of TFCC, although the reference is slightly outdated, but they say this press test is indicative of injury to the ulnar wrist pain. We just ask our subjects to press themselves using their hands off the chair to provoke the symptoms. So after we randomly assigned our subjects into 1 group of 3. Group 1 received orthotics, group 2 received orthotics plus strengthening, and group 3 control. We took our measurement at baseline 2 weeks, 4 weeks after randomization. Outcome measures were strength. We measured that using the JAMR dynamometer according to the guidelines of the American Society of Hand Therapists. Pain and function, we measure that using the Patient's Rated Wrist Evaluation Questionnaire, will be abbreviated as RWE. And for overall health, we use the generic SF36 questionnaire. And for this questionnaire, we use the aggregated scores in the first paper only. My outcome measure, the PRWE, is a 15-item questionnaire. 5 questions address pain, 10 questions address function. The total score is 150, and lower scores indicating better outcomes. In terms of the psychometric properties, the questionnaire has a moderate to high reliability, high internal consistency, good construct validity, and moderate concurrent validity. And it has been reported to be the most responsive outcome measures in subjects with distal radius fractures. The SF36 questionnaires address the 2 main facets of health, mental and physical health. We use the aggregated scores of these 2 main facets as our outcome variable in the regression analysis. In terms of the psychometric properties, it has a high internal consistency except for the dimension. So just let me walk you through the different steps in my research in this short clip. Something wrong with the sound, I'm sorry. So the movie was directed by Dr. Lohman, but he said he just directed him this video in his dream. So for the orthotic intervention, we used the Bauerfeind manual wrist support by Bauerfeind company in Germany, and this brace provided moderate to maximum support to the ulnar side of the wrist, thanks to a two metal stays, one on the ulnar aspect here and another one volary. The three laced straps provide moderate, comfortable pressure over the distal forearm and proximal hand, leaving thumb and fingers and radial side of the wrist free to move. The splint was worn all day and night, except for hygiene and for performing the exercise. For the strengthening exercises, we had 4 weeks home-based strengthening exercises. We used different tools, and for each of the exercises, it was progressive in nature. And the contraction for each exercise was hold for 6 seconds, repeated 10 times, and performed 3 times per day. The frequency were 3 times per week for 4 weeks, for 12 sessions. For the second paper, we had a correlation design. So we crossed over randomized our subjects from group 1 and group 3 to form 28 cohort group, one cohort group of 28 subjects that receive orthotics and strengthening exercises. We only analyzed the data based on the 4 weeks post-intervention. Since the ICF and the ICF course set for hand conditions are a conceptual frameworks, not a health measurement tool, it had to be represented by a quantifiable outcome measures so it can be statistically scrutinized. In doing so, we used the SF36 questionnaire to represent the health conditions of ulnar wrist pain. We used pain and strength as impairment of body function, and we measured that using the pain subscale of the patients of the PRWE dynamometer. For the activity limitation and participation restriction domain, we measured that using the specific and usual activity subscale of the PRWE. And that was our model applied to the ulnar wrist. Statistical analysis, for the first research paper, we had 3x3 mixed factorial ANOVA modeling to investigate the main effect of time and main effect of grouping, and then the interaction between time and group. If there is a significant difference between group, we used post hoc analysis using Panforoni test. We also performed a one-way ANOVA over the baseline characteristics just to investigate the criteria of our groups at baseline. For the second research paper, which was a correlation, so we used Pearson correlation 4 weeks post-intervention, and then we performed multiple hierarchical multiple regression analysis. For this multiple regression analysis, we controlled for our confounding variables like age and gender by blocked entry them into the model, and then we continued enter our predictors in a stepwise fashion using a stepwise entry method. What we get? First, we had a consistent result for research paper 1. For the strength, we had no significant difference between the 2 intervention group, while significant difference between the 2 intervention group, and same for pain, no difference between the 2 intervention group, and there is a statistical significant difference between the 2 intervention group and the control group over time. Consistently for function, we had no statistical significant difference for both intervention group over time, and statistical significant difference between the intervention groups and control group over time. For the second research paper, the correlation analysis, the Pearson correlation revealed a strong association in our predictors and the physical between one another, and between our predictors and the physical health component of the SF36 questionnaire. The highest association were between function and pain at R equal 0.92 and P value less than 0.1. There was no statistical significant difference between There was no statistical significant association between our predictors and the mental health component of SF, and there was no significant association between age and gender and the physical or mental health component of the SF. We to mention here that friend Abdullah Shehri found a similar results 2 weeks ago. He found a strong association between pain and the physical health of the SF in subjects with anterior knee pain. So it's good we have the consistent result with him. For the regression analysis, when we entered gender and age in the model, they by themselves predicted 22% of the variability in the physical health component of the SF36 questionnaire. The age was a significant predictor at alpha at b value of 0.05. When we entered other predictors in a stepwise fashion, strength by itself predicted 31% of the variability and improved the predicted capacity of the model to 53%. Pain and function were excluded from the model, and strength was the only variable that was retained in the model at b value of 0.001. So what did this mean? First, although we didn't have a statistical significant difference between the two intervention group, the group who received orthotics intervention showed a slightly better improvement in scores of pain and function as compared to subjects who received orthotics plus strengthening exercise. So it's always important to mention the clinical difference, although it was not statistically significant. In 2002, Laceteus said ulnar-based orthotics will not prevent the forearm rotation, but they just provide a comfortable and enough support to relieve some pain that associated with ulnar wrist pain. And the orthotic intervention is the mainstay of the conservative treatment, and those subjects will not be priority will not be directed toward the strengthening as much as it is for orthotic intervention. Strength may be the most studied health outcome measures used by hand therapists, and it is incorporated in different category of the ICF core set for hand conditions. This may explain the high predicted capacity of the strength score in predicting the physical health component of the SF36 questionnaire. Although there was no statistical significant difference between the two intervention groups, the group who received the strengthening exercise showed a slightly better improvement in mean strength score as compared to subjects who received orthotics intervention. Still some paucity in research regarding the use of TheraBand. We don't know actually how much resistance is provided by each type of the band, and whether or not the bands are contract specific. Only one trial in 2013 in Turkey tried to substantiate the resistance and the length of the band, and they concluded that future research is still needed in terms that we need more evidence how to standardize the use of the TheraBand in research and clinical trials. Although the patient's rated wrist evaluation was used extensively in literature, it was excluded from our regression analysis. We hypothesized two main reasons for that. Maybe the major improvement in grip strength superimposed the change in pain and function, or that the PRW itself was not able to identify the actual improvement of pain and function. Similar results in 2005 found low capacity of PRW in predicting health outcomes after distal radius fracture. Only explain 13 and 33% of the physical component of the SF36, and 10 and 8% of the variability in mental component of the SF6. Although, despite these limitations, we found the PRW more comprehensive and relevant to our subject with ulnar wrist pain. In the specific activity subscale of the questionnaire, we found activities like taking a doorknob using my hand, cut meat using a knife affected hand is directly related to the functional limitation that found in subjects with ulnar wrist pain. Also, use my affected hand to push up from a chair was directly related to one of our physical exam tests that we performed when we asked our subjects to press using their chair to kind of reprovoke the symptoms. Brink in 2009, future studies are still needed to compare and correlate the PRWE to the objective measures such as strength and hand function testing. So the limitation of my research was the small sample size. So we should be cautious about generalizing our results to other population. We only studied a specific source of ulnar wrist pain. We had a large unexplained variability that couldn't be identified in this study. We could only identify 53% of the variability in the physical health component. I think a large portion is still unexplained. We only used the PRWE and the grip strength to measure, to represent and correlated with the ICF core set for hand condition. We can conclude that orthotics intervention is as effective as orthotics plus strengthening exercise in reducing pain, improving function and strength in subjects with ulnar wrist. Grip strengthening exercise is not always as important as grip strength assessment. The brief ICF course set for hand conditions can be a useful subcategory of the ICF and should be endorsed by clinicians and therapists. Should be a part of the integral language, of the clinical language. Thankfully, we had 2 papers out of this research, as Dr. Lohman has indicated before. First paper submitted to the Journal of Therapy. The second paper is still under review by our committee. Okay, this is the most difficult part. I have to do it anyway. It's time to thank special people in my life through the past 4 years. I will start off with my respected committee. Dr. Lohman, when I first came here, the second day I was walking by his office, and then I saw a gentleman in front of his office. He smiled and said, "You must be the new Egyptian students in the physical therapy." I said, "Yes." And he said, and I said, "Who are you?" And he said, "I'm Dr. Lohman." And that was the start of the journey. I didn't know him, and he just recognized me from the start. So Dr. Lohman, thank you for being my teacher, my supervisor, my friend, and most important, I mean, you lead this department with a great deal of wisdom, and you have a very strong administrative skills. I always look up to that. Thank you for helping me writing my dissertation. Thank you for perfecting my writing, and thank you for helping me keeping my momentum. Dr. Noha, before I came here, I didn't know how to use the SPSS confidently. Thanks to her, I'm independent now. I'm using it with a great deal of confidence. Dr. Noha, thank you so much for being my instructor, my statistician, and most importantly, second mom. And this is my mom would be jealous, but but you have a great impact on my life through the past 4 years. Thank you so much for your support and kindness. Dr. Said Hassan, he called me this morning and apologized for coming, but he helped me a lot with the recruitment stage. He's an orthopedic surgeon from the medical center. This person I would not forget. I mean, the first day I arrived to Loma Linda, she was waiting for me in her office after her working hours, just to make sure that I arrived safe. The second day, she walked me to the registration, just making sure that I completed my registration. Sandra, I mean, I'm speechless, but yeah, you are the sunshine of this department. You supported us, you helped us a lot. Thank you for being so dedicated and supportive. Thank you. I didn't see Dr. Canizales today. my friend Payne, Dr. Payne, thank you so much for your coordinating me with the IRB. It's always helpful to have someone in the department that coordinates with the IRB, because it's a paperwork, and it's not funny. It's not fun to do the paperwork IRB. So thank you, Dr. Payne, for that. Dr. Canizales, I wish I could see him today. I thank him for his guidance through the dissertation. I'm sorry, is he? He is here? He's not here. No. I thank him for his guidance through the writing of my dissertation. And if you know Dr. Canizales, you can tell that he has a large attitude while he speaks. He speaks like a president. So I always learn from that. He has this attitude. Yeah. So thank him. Special thanks to the doctors and colleagues who showed up at my poster at the combined section meeting last year at Las Vegas. Dr. Lohman, thank you again for mentioning my name, acknowledging my poster at the lunch meeting of the students of allied health professions and faculty. Dr. Swen, Dr. Howard, my dear friends Mazen al-Gahtani, and soon to be called Dr. Faisal al-Mubarak. Oh yeah. This picture, I love this picture so much. This shows my passion to hand therapy, but except that this passion is ortho neuro, my passion is ortho. So Dr. Johnson, thank you so much for your knowledge. Thank you most importantly for your humbleness. You are a true example of Loma Linda core values. I would never forget your classes. Thank you so much. I love this picture. It shows how we were a little bit younger 3 years ago, and and also it's a proof that time flies. See how some of us here graduated. I'm graduating today. Some will graduate soon next year, or probably the year after. Special thanks goes to my roommates, my ex-roommates, Dr. Abdallah Laitavi, Dr. Abdullah Isbihin, our future Dr. Hatem, and special thanks goes also to my current roommate and my friend who helped me a lot today, and the best few weeks, our future doctor, Dr. Fahad al-Shihri. Thank you so much. Okay, so I'm a single person. I don't have a wife to thank, but and I'm living stress-free, if you know what I mean. No offense to anyone else. But at the same time, I have a very sweet family to thank. I come from an artistic family. My father is an artist. He does an Arabic calligraphy, and he has a lot of exhibitions over the Middle East and Africa. My mom is an electrical engineer. My brothers and my two little angel, my nephew and my niece, who are the source of joy in my life. This is my second family. This is my second place when I was here in the past 4 years, the Islamic Community Center of Redlands. These people supported me much. They stood by my side. I wouldn't forget their support over the past 4 years and the love and compassion. I'd like to thank the Board of Directors, the Board of Trustees, and especially I will start with my dear respected brother Salah Swani and his family. Thank you for coming today. My dear respected father Abdul Qadir, thank you so much for coming today, and his family. Respected brother Dr. Khalid Bahajri and his family, and my dear respected sisters Sana, Flora, and Dunya, who all embraced me with their love, and their families, and the all lovely kids and the community who just made up my days through the past 4 years. Thank you so much. Yeah, I forgot to do that. So. Where is it? Yeah. At the end of my presentation, just allow me to put this around my neck to show my appreciation to my country, which sponsored my education through the past 4 years. And it's and I am the first Egyptian physical therapy student since 2001. For some reason, they don't like to send out BTs. But I was lucky enough to be here. Dr. Hussam Kamel, former president of Cairo University, invited me to his office, and he encouraged me to go outside and learn and study for my PhD. So he believed in me as much as Loma Linda Institution and Dr. Lohman did. So thank you, both Cairo University and Loma Linda University. Thank you so much for your attention. We can take some questions now.
Questions? Before you
Yes.
ask the question, let me get the mic to
You have the mic there? Yeah.
Hello, test.
Mm-hmm.
It's not going to speak. Just speak normally.
Oh, okay. Maybe a two-part question, I guess. Were you expecting a difference between the orthotic and strengthening? Were you expecting a difference between the two intervention groups?
Yes.
And which way were you expecting?
Yeah, logically speaking, if you are talking about strengthening exercise, the group who received the strengthening exercise should have shown significant improvement in strength scores.
Mm-hmm.
Another factor is pain and function. Group who received orthotics intervention would have slightly better improvement in pain and function scores, and that was evident just clinically, not statistically.
Okay. Just one more. The TFCC is kind of like the knee in regards to like the meniscus.
Yeah, it's analogous to the part of it, not the all.
Not
structure,
exactly,
yeah.
but it's close. Yeah. There's some in regards to the knee that you can, a young person can tear the meniscus, and then an older individual can have degenerative tears.
Yes, it's the same there.
It's the same?
The same classification. We have traumatic versus degenerative classification for the TFCC.
Yeah.
But I didn't show that here. I showed it in the topic defense. I had more time. But yeah, we had 4 classifications for traumatic injuries and 4 classifications for degenerative injuries.
Do you think that might have been the reason why the 2 interventions didn't differ, maybe?
Yeah, maybe the delimitation for the sample size. We just opted to use subjects with acute and subacute ulnar wrist pain. So maybe if we or a sample included subjects with chronic pain, maybe the results would have been
That's
different.
what I was trying to ask. Okay, thanks.
Grinder.
I just have a comment. I think that was one of the best presentations I've seen. It was excellent. And I think the students in the room should actually recognize the passion that you have for your topic, because if you have passion in your topic, you know, it was just flowing out of you today.
Yeah.
And it wasn't just in your presentation, but actually how you presented your
Thank you.
material. It was excellent.
Thank you. Thank you so much, my friend. Thank you.
Mohammed, I just want to thank you for an excellent presentation. I'm going to build on a little bit what Dr. Bain stated. Sometimes when students come to my office and we start talking about possible topics, I have to pull the information out of them and kind of guide them. I just sat back and you just unfolded this elaborate strategy in front of me, and I've been holding on, trying to keep up with you now for the last 3.5 years. So thank you for just being so dedicated. You're truly a hand expert. You already have multiple publications in the hand, and I hope that you continue that focus. Okay. And I believe that in the near future, we'll be seeing you in a home study course by the American Physical Therapy Association or some other organization. I really think it's important that you validated an algorithm. Algorithms are helpful and useful, but there was some missing evidence, and you supplied that evidence, and so that's greatly appreciated, and it's going to be very useful to our profession, not just our profession, but any profession that treats patients with hand and wrist pain. Lastly, just a comment. I love the fact when graduates quote each other in their research, and so I don't know why that just does a warm spot in my heart, but it was fun having you quote Abdullah's research and how it correlated with yours, and have similar findings. We have 7 Doctor of Science students that will be participating in commencements this year, so this has been a very busy, abnormally high outcome for our department, and I'm just proud of all of you. On May 26th, Adil will be doing his dissertation defense. I think that's the last in our department of a very busy year. So anyway, I just want to thank you publicly for just being passionate for research, passionate and for the hand and wrist, and just being a super advocate for not just Loma Linda University, but Cairo University as well.
Thank you so much.
Good morning, everyone. First of all, I would like to thank you, Mohammed, for inviting me today to come and attend this. I'm not in physical therapy altogether. I actually joined Loma Linda University about 4 or 5 months ago as a faculty in the Transplant Institute. I'm a transplant hepatologist. And I met Mohammed only once actually at dinner, and he invited me, and I made sure that I would come today to just support him morally. But in fact, he got me really interested in the topic, and I listened to it. I like the design. I like his comment actually on the sample size, which is really, again, is something to consider in generalization of this topic. And again, I would just add my comment to the Dr. Luman and your colleagues in really applauding your presentation and your composure, so to speak. Thank you again for inviting me.
Mohammed, you know how much I enjoyed your topic defense. At least once a quarter I remind you about it. And today's presentation was equally as strong, particularly the way that you presented with a command the statistics. That was remarkable. Dr. Lohman mentioned that you had future plans, so I just would like you to briefly state where you go next.
I'm considering a residency program, so I'm just searching for a place here in California. I'm licensed in New York, but I applied for my licensure here in California as well. I'm a PTLA. This is what they call the physical therapy license applicant. So considering that, I like to continue in my professional career, and I would like to be an OCS in the future. So it's a step just before the OCS, hopefully.